Once again, welcome everyone. Thank you so much for joining us today. And I am joined by my colleague Dalina and also Dr. Enrique Croce and our expert, Dr. Gaetano Gallo from Italy. And also our expert, Edoardo Cervi, will also connect soon. So just to give you a quick overview of today's session, so we will have some theoretical backgrounds and some practical insights, in some cases. And we will have more or less 40 minutes of presentation and then 20 minutes of open discussion. We would be really happy for an interactive session, so please be free to use the chat and the Q&A section to ask your questions and share your thoughts. So now I'm very happy. It's my pleasure to introduce you to our speaker tonight. This is Dr. Gaetano Gallo. He's a professor of surgery in Milan and a specialist in Coloproctology. And Dr. Cervi, who is not yet here but will join soon, he's a professor at the University of Brescia and a specialist in vascular and general surgery. And Dr. Gallo, if you would like to start.
Thanks very much, Alexandra, Dalina, Eric, especially for our friendship. And I will now share the screen. So thanks very much for the invitation, for the opportunity to be here with you discussing a special topic for me that has an important place in my clinical practice. So please confirm that everything is okay now that I'm sharing the screen. Alexandra, everything is okay?
Perfect.
Okay, that's it. So, well, again, it's a pleasure for me to join this panel, and I will explain you how sclerotherapy with 3% polydocanol foam and, of course, the special device used to obtain the foam, they are revolutionizing the world of office-based treatment. So first of all, why using sclerotherapy for hemorrhoidal disease? Why choose a non-excisional treatment? Well, hemorrhoids, the first reason is that hemorrhoids are physiological structure, as it's a good decision to preserve them if possible. Indeed, they are able to contribute both to the resting anal pressure and defecation, of course. So this is mandatory to be considered. Well, the second reason is that hemorrhoids can be a source of life-threatening gastrointestinal bleeding that require transfusion. And you know that the most common symptom of hemorrhoidal disease is painless rectal bleeding, is not prolapse. And for this reason, we should consider that sclerotherapy is a symptomatic approach, especially for bleeding. So if we should consider the best indication, bleeding, symptomatic bleeding hemorrhoidal disease is for sure the best indication to apply for the procedure. And the third reason is to avoid postoperative pain, because we know that sometimes we need to perform, of course, excisional hemorrhoidectomy, but there are some scenarios in which we can avoid excisional surgery or non-excisional but painful procedure in order to allow a faster return to normal activities to our patients. So this is the third reason, and I will show you one more reason to apply for. But we should consider that sclerotherapy with 3% polydocanol foam has become popular for the treatment of first, second, and third degree hemorrhoidal disease symptomatic patients in whom conservative treatment fail, as we report in our guidelines of the Italian Society of Colorectal Surgery. The first attempt, the first surgeon to describe the use of a sclerosing agent, the iron sulfate, was John Morgan, an Irish surgeon working in UK. And after that, many other agents have been using during the last century, of course, and polidocanol, that basically is a non-ionic detergent, begins to be used in the 50s, but only from 2007 has begun to be used also in the proctological field in the foam formulation. And actually, for us in Italy, it's the best sclerosing agent to be used, and the only one allowed from our national, our IFA, that is the National Society for Drug. But going right to the foam, why using foam? Because foam allows lower concentration and volume to be used to achieve successful treatment, because it allows homogeneous distribution of macro bubble inside the vessel, because we need in hemorrhoids something acting locally and not going systemically. And one of the main reasons is because sclerotherapy provokes this immediate action, just 2 minutes after the injection, with fibrosis and sclerosis. With the automated device I will show you, you should consider that we reach this ideal sclerosing foam that offer desirable physical and biological performance, with cohesive and stable foam, damaging all the cell in the treated area and not with systemic effect. Concerning the pathophysiology, sclerotherapy provokes a consistent inflammatory reaction which results in a localized sclerosis of the submucosal, of the hemorrhoidal tissue, to the underlying tissue. So what does it mean? It means that this is the fixation, the scarring of the hemorrhoidal tissue. That is exactly the first effect of sclerotherapy. The second one is the shrinkage. The shrinkage is provoked by the obliteration of the vascular bed, as you can see on the left-hand side of my screen, in and near the hemorrhoidal node, so reducing, downsizing, downstaging the hemorrhoids. And this is exactly the fourth reason to apply for the procedure, because we studied the arterial flow patterns in healthy individuals and in patients with hemorrhoidal disease using a Doppler transperineal ultrasound in order to understand the vascular contribution to hemorrhoidal disease pathophysiology. We studied the vascular pattern and we studied the scatter pattern. But if you take a look on this slide that I'm showing you, we compared first and second, third and fourth hemorrhoidal disease degree, and the peak systolic velocity was pretty much higher in patients with third and fourth degree hemorrhoidal disease. This showing us the contribution of the arterial hyperflow in the pathogenesis and giving us the reason to apply for the procedure. And indeed, I will show you this slide. This is two pictures concerning first on the left and second on the right, patient with hemorrhoidal disease. And here again, the vascular pattern of a third degree hemorrhoidal disease, symptomatic hemorrhoidal disease. And here again, and fourth degree hemorrhoidal disease, here is evident that the peak systolic velocity is much higher compared to the previously described procedure. In my lecture, I will not show the endoscopic approach, but I will show you the result obtained with the endoscopic sclerotherapy that is useful as well, exactly like as the transanal approach. And here we exactly reported the result obtained from our scientific activity to clinical application. Indeed, in this series of patients, we demonstrated that after treatment, our patients show a significant reduction of the peak systolic velocity and of resistance index after 7 and 30 days. And this was consistent as well after considering patient-reported outcome measures. Well, now I showed you the reason why we use the foam. Now I will show you how to obtain the foam. Well, we have several methods. We have several procedure that several device that can be used. We have the Tessari method that is the most widespread, that was the most widespread until a couple of years ago. Afterwards, I will show you two principal techniques: DC foam kit, syringe system, and the automated device that is now that represents now my routine clinical practice. Well, at the beginning of our experience, my experience, we used to obtain the standardized foam using this syringe system that consists of two silicone reduced syringes with a two-way valve connector, and is optimized for the generation of a fine bubble, homogeneous and stable microfoam. So we mixed 1.6 milliliter of 3% liquid polydocanol and 7.5 milliliter of sterile air. So 1 to 4 more or less is the combination. And in this case, we need to re-emulsify the foam 20 seconds before each injection. So we need to do that in order to maintain the consistency of the foam. And our results were, of course, honest, and published for the first time in 2018-2019. I will report some technical details. Of course, you can obtain the foam in the way you prefer, but I mean, in this first publication, we use a DC foam kit syringe system, but now our practice is mostly all about the automated device I will show you. But concerning general technical details, well, enema 2 hours before the procedure, no antibiotic prophylaxis, and diet rich of fiber for 1 month postoperatively. The foam was obtained as already described, so you should have this ratio 1 to 5, 1 to 4, 1 to 5. And before each injection, if you have the automated device, you don't need to re-emulsify the foam. Otherwise, you need to do that for at least 20 seconds. And we use 2 to 4 cc of foam for each pile. Or, as I will show you, the injection of the polydocanol foam can be performed in the triclassical pile or in the bleeding area, because you can tailor the procedure based on the patient. You do not need to perform in the classical 3 piles described, for example, by Milligan Morgan. You could perform the injection in the bleeding area. So 2-4 cc per pile without exceeding 10-12 cc of foam per procedure. And all the patients were treated in the Sims position, left lateral decubitus in our outpatient clinic, using a 20-gene anesthesia needle, and the patient were not sedated and no local anesthesia was used. Well, we inject the foam exactly into the pile and not in submucosa in order to obtain the maximum efficacy thanks to the fibrotic suspensory reaction. Well, as you can see here, one important technical detail is the inclination of the needle that should be tangential, especially of the level of the right anterior pile, so 11 o'clock position in male patient, especially in order to avoid prostatic and urinary complication. And what is important is to perform the procedure above the dentate line to avoid postoperative pain. Well, so after the easy foam kit, as I showed you, we have been using this automated device for more than 4 years. So since the beginning of the publication of the device, this is our first publication that actually is the first one described in the literature concerning hemorrhoidal disease. The foam have demonstrated to have an absolutely stable consistency, higher median half-life compared to the foam obtained using the Tessari method. Moreover, the device allows the use of different percentage of polidocanol or of any other sclerosing agent, but while maintaining a liquid gas ratio of 1 to 5, 1 to 6, 1 to 7, but 1 to 5 usually, and it constantly re-emulsifies the foam during the whole duration of the procedure, reducing the human error. So you can standardize the procedure as it's not operator dependent, and the results were really amazing in our publication and afterwards. Well, now I will show you how the system works. This is our published video on colorectal disease YouTube channel. Well, this is the system consists of this dome-shaded capsule with the luer lock, both for the injection and removal of the sclerosing agent, and the magnetic stem on top. Of course, you don't need to close again the luer lock, but it's just a demonstration. And here you can see the consistency of the foam. On the left-hand side, our anoscope, open-ended anoscope, 18 millimeter more or less, no more needed, and the 20G needle used. We don't need a bigger anoscope because this can be painful, and this is the special consistency of our foam. Now we can go directly through the procedure. We are going to identify, as you can see, the dentate line. We have the pink one is above, the violet is below, and this is exactly the dentate line where to obtain the foam. Now we are withdrawing the foam 2,4 cc, and we are injecting our pile. Now we are moving, and I will show you the exact. Okay, this is exactly what we do usually. So you can see the dissemination of the foam all around. So it's not only an injection performed at 3 o'clock, but at 3, 4, and 5, thanks to the dissemination of the foam. And here again. Well, patients were asked to walk for approximately 20 minutes before a pre-discharge check. So we performed the procedure without anesthesia and without sedation or local anesthesia, only with lidocaine gel. So again, this is an educational video obtained using a video anoscope and our VARIXIO, our automated device. Our landmark is the dentate line. You can see this carrying effect from, so the piles, I'm not moving, but it's the pile moving from the upper part of the slide to the lower part. This is exactly the mucopexy performed with our technique. This is the first one is second degree, this one is a first degree hemorrhoidal bleeding hemorrhoidal disease, and afterwards I will show you a third degree prolapsing hemorrhoidal disease in patient under anticoagulant therapy. So we can perform the procedure as well in those type of patients. So this is a third degree hemorrhoidal disease patients. You can see how big is the pile, but we are going to inject it with amazing result. We are able to stop the bleeding at all. And now one more injection after that. Just to explain you that when you have 3 different piles to be injected, you should perform at the beginning the smaller 2, and afterwards you need to perform the bigger one, as in this procedure. So contemporaneously, no problem to perform 3 or 4 injections contemporaneously. Okay, and I will explain you this in a couple of minutes. This is our multi-center study. We work very hard to obtain this, more than 5 years, with an Italian group publishing these 2 studies. As you can see, this was a multi-center, open-label, single-arm phase 2 trial involving 10 tertiary referral centers. This actually is the only one published in the literature concerning the long-term efficacy, 3-year efficacy of 3% polidocanol foam in the treatment of second-degree hemorrhoidal disease. And the most important feature is that our primary outcome was the success rate after one sclerotherapy session in terms of complete resolution of bleeding 1 week after the injection. Because the interesting part of the interesting characteristic of sclerotherapy is the immediacy of the action. So just 2 minutes after the injection. And here you can see the result. We performed in this period 183 sclerotherapy. Most of the patients were male. The mean operation time was, well, 7 minutes, so really fast, but not so fast. I mean, it's a correct time, honest time, really, applied to our clinical practice. Only 23 patients experienced procedural pain with a median VAS score of 2, so it's almost nothing. And in 1 week, we were able to obtain a complete resolution of bleeding in almost 70% of the patients. That increased to 95% after 1 year and decreased a bit after 3 years to 90%, with a slight increase of the occurrence rate and of the proportion of patients who transitioned to surgery. That was 7.7%. That is not a lot, but I mean, it's the normal scenario when treating this type of patients. And we repeated the procedure in 2 times in 20 patients, 3 times in 3 patients, so 1% of overall our percentile of patients. What was interesting, it tests almost 75% of the patients were symptoms free. So what does it mean? It means no itching, no prolapse, no bleeding, no pain, and no mucus discharge. So to summarize our publication, we obtained the procedure. We summarized the procedure to be cost effective, to be repeatable with complete absence of discomfort. We know one of the previously described complication with all the other sclerosing agents described so far. Now, just to explain you some technical detail concerning the timing, well, ideally, to allow sclerotherapy to be effective, it is better to wait at least 4-7 weeks before performing the second session. And afterwards, unless there is a life-threatening bleeding, the time window increases. So 4-6 weeks between the first and the second. Then you need to wait 3 months to perform the third one, and 12 months to perform the fourth one. So you can repeat the procedure, but we need to wait this period in order to allow the foam to be effective. And another important clinical trick is the post-operative treatment with local and systemic therapy. Precisely, well, we demonstrated the preoperative effectiveness, because it's important as well, of the micronized purified flavonoid fraction and this sucralfate-based rectal ointment in those type of patients. Well, we administered this therapy 60 days before the procedure, completely blinded, and after the reevaluation of the patients, as we show in this patient, we obtained amazing results, because we decreased not only the size and the stage of the hemorrhoidal disease, but we decreased the severity of the procedure to be performed. So preoperative procedure is useful, but post-operative procedure with stool softener or laxative and locally acting flavonoids, so systemic are needed absolutely. The only one procedure that can be combined with sclerotherapy, just going to the comparison and the application in clinical practice, is rubber band ligation. And here you can see our Portuguese colleague that compared sclerotherapy with rubber band ligation in patients with first, second, and third degree hemorrhoidal disease. If you take a look to the red column that is about rubber band ligation, the group needed more office-based session than sclerotherapy to reach the success. So sclerotherapy was better, and the difference was significant, especially for second and third degree hemorrhoidal disease. What does it mean? That the number of interventions increased for rubber band ligation to attain the success, but not for sclerotherapy. And going to the complication and recurrence, both complication and recurrence were associated with rubber band ligation. So sclerotherapy was really better. Well, we know we are surgeons, so sometimes we cannot apply for a non-excisional procedure, so we need to respect the indication, and excisional hemorrhoidectomy still remain the gold standard in those type of patients, so in third and fourth degree hemorrhoidal disease. Indeed, we recommend to perform the procedure on no more than 3 piles and to preserve the mucocutaneous bridges in order to maintain the elasticity and caliber on the anal canal, avoiding anal stenosis and the complications that are described in this paper that you afterwards need to be solved. So what to do? In this case, we performed excisional hemorrhoidectomy, but there are some residual pile that could not be removed. So in this case, we performed sclerotherapy on the residual pile, and we published our paper. So from the bench to the bedside, like translational surgery, to evaluate the surgical outcomes and efficacy of the combined treatment of excisional hemorrhoidectomy and sclerotherapy on the remnant mucocutaneous bridges. And we evaluate the patient for 3 months at enough for this specific outcome. And you can see that we perform excisional hemorrhoidectomy exactly as described traditionally as first procedure, and afterwards we perform the sclerotherapy, as you can see on the left and right hand side, and an average number of 2.6 files were removed, but interestingly, we performed sclerotherapy on average on more than 2 piles. That means that sometimes we cannot treat the symptomatic pile for the really problem of a possible anal stenosis. And so, of course, because we removed the pile and we performed sclerotherapy, the results were amazing. And with the improvement of the basic continence score of our patient-reported outcome measure that you can see on the right-hand side. And if you have any doubt about the usefulness, you can read this amazing paper conducted with our Chinese friends, published on Disease of the Colon Rectum, that is the best colorectal journal in the world. This is a randomized controlled trial. Well, the results were consistent with the previous one reported in Updated Surgery. We demonstrated a mean 6-day earlier return to normal activities and work than the control group, as has been demonstrated in this figure 3 reported here. Well, now going to the conclusion, this is the only one systematic review published in the literature about sclerotherapy for hemorrhoidal disease. We investigated all the sclerosing agents used in the last 40 years. About 44 papers were included in our review, reporting that on almost 10,000 patients. Well, 17 randomized controlled trial. Most of the study were conducted in Japan, in UK, in Italy, and in Portugal. And you can see that the anoscopy was the most adopted route. The most frequently injected agent was polidocanol. The study method was, until 2022, the most used technique to obtain the foam, and the needle caliber ranged from 20 to 25, because 20 is for the anoscopic approach, 23, 25 is for the endoscopic approach. Most of the procedures were conducted intrapile without anesthesia, and of course, procedural pain is the most common reported problem. We were not satisfied, so we decided to conduct a meta-analysis of available randomized trial in order to compare sclerotherapy with the control intervention already there flavonoids, coagulation, rubber band ligation, liquid polydocanol, and as well RR, so recto-anal repair with hemorrhoidal artery ligation under the Doppler guidance. And well, the results were amazing because sclerotherapy was never inferior in terms of success rate and recurrence rate, but was better in terms of fewer of complication rate. And this is only about 2022 because now the results were very much better compared to the control group. If you would like to have a guide, well, we published this paper last year. This is an international survey of experts, a systematic review of polydocanol foam, and the clinical practice recommendation on indication and contraindication, perioperative management, procedural detail, postoperative care, and comparative effectiveness. So, I mean, you can download this because it's open access in order to have a guide completed for your clinical practice. Of course, about polydocanol foam, we already demonstrated that there are no generalized complication reported in the literature, apart from this rectal abscess that has been described by the Portuguese using 1% or 2% polydocanol, and this is not very well described, so it was treated conservatively, so it was not a rectal abscess for sure. We never experienced that, never been described so far. So in conclusion, indication for sclerotherapy, well, apart from first, second, and third degree hemorrhoidal disease that are already demonstrated, we can use it in patients with bleeding disorders, with life-threatening bleeding, in patients that will not stop the anticoagulant therapy, as has been described by our Portuguese friends. We can use it in elderly patients who cannot undergo surgery with or without comorbidities. We can use it as a bridge, as it was exactly during the COVID-19 pandemic, and we can use it for patients already undergone surgery in order to preserve the elasticity and the caliber of the anal canal in combination with excisional hemorrhoidectomy, and more because this author published as well the efficacy in patients with inflammatory bowel disease medically controlled. So they demonstrated how the procedure is promising, is painless, repeatable, and most of all low cost, using the correct approach, the correct device. That the automated device I showed you is the best, is actually should be your clinical daily practice, should be used daily in your practice, and of course adapting in the correct patients. Well, so thanks for your attention. I'm really happy to take questions from the attendants and from the participant. And thanks again, Eric, Alexandra, and Aline.
Well, we have a question here from Dr. Rosa. I'm gonna read it. She asks, management of pain after treatment strategy.
Okay, so do you mean pain after sclerotherapy?
I believe so. That's
Okay.
what she said.
Well, sclerotherapy is painless because the procedure is performed in an area that is above the dentate line, in which there are not nerve about pain. There are only nerve that the feeling of tenesmus maybe of the patient, the feeling of heaviness maybe. Yes, after you should not experience pain, because the only thing that is painful maybe a bit is the anoscope that is really thin. It should be 18 millimeters, so no patient at all, because no pain at all, because if you have the pain, it means that you have performed the procedure in the wrong way. Even at home, painkiller are just when the patient need, but I never ask patients, so please take painkiller each 6 hours or for 1 week. No antibiotic, no painkiller, usually standardized. The procedure is painless. If they have some pain, you can use paracetamol, for example. But for example, if I should tell you how many patients, is 1 out of 25, 30 for the endoscope, not for the procedure. Lidocaine gel as well. Lidocaine gel as well.
I don't know if somebody has another question. Here is one. Do you have any experience combining
It can
LHP?
be it can be laser. Yes, it can be performed, of course, but LHP is one of the non-excisional procedure that can be performed on more than 3 piles. But you can do that. You can do that. But it's better to do that when you use a excisional procedure. But with LHP can be useful as well. With laser, also with hemorrhoidal laser procedure, with help.
So thank you, Gaetano. Probably with Edoardo Cervi, he's going to present his experience. But one comment I want to point out is probably people are afraid of having a sclerotherapy treatment of the hemorrhoids because they are thinking in the typical thrombosis. Probably the people are they don't want to, or they are afraid about that because they say, okay, maybe the thrombosis of the pile of the hemorrhoids is very painful, and then they think maybe when you are injecting foam in there, there is a thrombosis.
This is a technical mistake of the surgeon doing that. So if you have thrombosis, that means that you perform the procedure not well enough. Of course, it can happen once per 1,000 patients, but usually if you perform the procedure correctly, it is really rare. It is really rare. We have done a huge work, Eric. You know that because we publish I don't know how many paper, and our clinical practice is really. I used to perform not a lot compared to China, all the country I've been in the Asian population, but I used to perform 200 sclerotherapy per year, and they are very selected patients, very selected. So it's 200%, it's 200 sclerotherapy, and then I used to perform all the other procedures. So I'm not a sclerotherapy man. I tailor the procedure on the patient. So
okay, thank you very much, Gaetano. Maybe we can have we give the word to Edoardo Cervi, and
absolutely.
then if you can stay until the end, Gaetano.
Yeah.
Perfect.
Yes.
If not,
Ciao,
thank
Edoardo.
you very much. Okay, Edoardo, yeah, mute. You are in mute. Not yet. We can't hear you. No se te siente. Non ancora.
There is academic delay. Hello to Edoardo.
No se siente, Edoardo. ¿Tú me sientes?
Sì.
Yes.
Sì.
Ci sentiamo.
Puoi provare a connetterti, a disconnetterti e connetterti?
Yes.
Sì, prova. And in the meantime, Edoardo is doing that.
Yes.
I have
Please
a question
go.
for you, because
Pleasure.
I've been thinking in when for the treatment of varicose veins in the esophagus, is the same. I don't know. Maybe in Spain, it is a procedure performed by endoscopic surgeons, but what do you think about the indication in those cases?
So do you mean for the bleeding of the varices?
Yes, yes, varices in the esophagus.
Well, the foam is for sure well acting in those type of patients, Eric. There are some paper about in the literature. There are some paper concerning the use of sclerosing agent more in general, not only polidocanol, for those type of patients. There are some paper about thyroid cyst. There are some paper of thyroid. There are some paper about rectal prolapse in children. We have not a lot of, we have no evidence during pregnancy, of course, but I mean, it's a good solution.
Yes, I believe we can hear you.
Edoardo?
Kike.
Yes.
Okay, it's okay now.
Perfecto.
Yes.
Go ahead.
Okay, fantastico.
Grazie.
Okay. You see my presentation?
Not yet.
No.
Oh. Because I'm sorry, I'm in Sicily, in Palermo.
Wow. Amazing. Amazing.
I have it here. I don't know if you want me to share for you.
Yes. Can you see my presentation? Because I have the problem with the internet.
Let me.
I think go ahead, Alexandra. Yeah. So it's Dalina. Yeah. Go ahead. Yeah. So.
Can you see that?
Oh, it's
Yes.
okay. It's okay.
Well, whenever you want.
Okay, thank you so much. I tell you when the next next part. Okay, thank you so much. Ciao Gaetano, ciao Kike, hello everyone. I agree with Gaetano for all the presentation, and a very congratulations for your presentation. But I know your experience, and I present myself. I'm a vascular and general surgeon. I use VARIXIO medical device for varicose vein and for hemorrhoids. And my first experience in the varicose vein and the second experience in the hemorrhoids. And I think that Gaetano is one of the first general surgeon proctologist that perform the treatment of sclerotherapy with foam, because you know that the first treatment for hemorrhoids had the sclerotherapy with liquid, and the foam sclerotherapy has changed the world of phlebology. Kike, you know this one, and it has changed the hemorrhoids approach for the treatment of this pathology. Please, the next one. Okay, the next one, this is my disclosure. Okay, you know that hemorrhoids is a common pathology in countries. The endoscleromus procedures of symptomatic hemorrhoids is very effective, painless, and without complication. Maybe I repeat the same things that Gaetano spoke, but it's very important to know the technique. And the sclerosmooth techniques is a technique is very safe procedures and very easy procedure. Because when I speak with the vascular surgeon, it's, oh, the hemorrhoids is not my field. Yes, but this technique is very simple. It's like to sclerotherapy for the varicose vein. The next one, please. Causes. Obviously, family history, constipation, diarrhea, diet, sedentary work, sport, and pregnancy. This is very important to speak with the patient, because you have the recidived, also like a varicose vein, and you have many problems. And this is the technique that you can repeat. You can read it because it's sure that you can have the recidived. The next, please. Two types of hemorrhoids. internal, external. This is very important. Yes, I know that we are surgeon, we are vascular surgeon, we are general surgeon, but very important to remember that when you the dental line, because this procedure is without pain. And this is very important for the patient. I speak with the patient. With the patient, I speak about the importance that this technique is without pain. The next one, please. Yes, this is the signs, symptoms: pain, itching, mucositis, rectal bleeding, edema, congestion. And I agree totally with Gaetano. The sclerotherapy is the best for the bleeding, because you can treat the patient also with the anticoagulation without stopping the anticoagulation, and you have the stop immediately of the bleeding. The next one, please. You know, obviously, the classification. I think that this therapy, sclerotherapy with foam, is very interesting for the first degree, for the second degree. For the third degree, you can to associate another technique. For example, the elastic technique with the sclerotherapy. The next, please. The literature. The literature is very important because, just a moment, excuse me. Hello? Yes? You heard me?
Yes.
Sì,
Okay,
sì,
fantastic.
sì, sì.
Okay, gracias. Oh, the sclerotherapy, in the literature, you have many papers. You have many literature. Gaetano show us the literature about the sclerotherapy, and Gaetano is the protagonist of this paper. Another one, please. And this is very interesting because this is a paper about bleeding disorder of hemorrhoid. This foam sclerotherapy is the best choice about the bleeding of hemorrhoids. The next one, please. Two techniques. The first one, anoscopic technique. Okay, the next. This is the position on the left, the next one, and this is the materials. I use this type of anoscopic. I have a video. The first pictures is a video. Please, if you can show the video. This is
I just have the PDF, so I
okay,
think that it's
okay,
not going to be possible.
No problem. Okay, yeah, no problem. This is anoscopic. I use this type of anoscopic and this type of needle. The next one, but this is possible to use another type of needle. This is for lumbar puncture, and this is another type of needle can you use. The next one. Materials, obviously, anoscopic, lubrificant, anesthetic, sclerosing agent. I use polydocanol, 3%, because you know that in Italy, only the 3% of polydocanol is on the label for the treatment about hemorrhoids. This is syringe. I use 5 ml, and obviously the cannula. The next one. Gaetano spoke about the preparation of foam. The first preparation of foam was Tessari. Everyone know the Tessari method. The Tessari method is easy, is very simple, and is not expensive, for sure. But the next one, what is important, the VARIXIO. It's important because it's important to prepare a standardization of the foam, l'automization of the foam, because everyone prepare the foam and is a different foam, but with this device, the foam is the same for everyone, and is very important also for the studies. With the standardization, uh, I remember Eric when speaks about the VARIXIO, and I agree with you. How you prepare the mayonnaise, manual or with device or with the machine? I prepare the mayonnaise with the machine. I remember your picture. As for me, it's fantastic. That it's very important for everyone to prepare the same foam. You can prepare the same foam only with an automatic device. The next one, please. Gaetano is the first that published a very interesting study about the use of VARIXIO with the hemorrhoidal disease. The next one. And is obviously for the moment VARIXIO. I know there is other machine, but for the whole authorization for the Europe, for another country, the VARIXIO is for the moment is the only, I think, machine for the authorization machine for the phone. The next one. The, I think this is the most important imagine about that explain the role of VARIXIO. Okay, attention. Piston effect. What is it? If you prepare a dry foam with homogeneous bubble diameter, the foam is more stable, has more stability, and because the effect, and I study this this effect, piston effect in the vein, but it's the same for the hemorrhoids. If you prepare a dry foam, a perfect foam, the effect of the foam is to move blood, and only the foam stay in the vessel, vein on hemorrhoids, and the action of sclerosant is more important. But if you prepare a wet foam with heterogeneous bubble, you don't have the same possibility to move the blood and to have a a best sclerotherapy effect. The next one. This is an effect that you have in the vein, but it's the same for the hemorrhoids. Dense foam facilitates spasm and the piston effect can displacing the blood. If you don't prepare correctly the foam with manual method, because not all the doctors has the experience about the preparation of the foam, because the foam is normal for vascular surgeon. It's normal for me. I prepare with the Cervi method for the varicose vein. 20 years I treat the varicose vein, but for the proctology is not the normal to treat the hemorrhoids with the foam, and it's very important to prepare a correct foam to have a correct effect. The next one, please. Okay. Then, with use the proctoscope, the sclerosing agent is injected directly into the surface on the enlarged hemorrhoidal node. You can use. There are many types of proctoscope. I show you my preferred proctoscope for the treatment of hemorrhoid. The next one, but is very important. This one. This one is the Bigman number. What is it? Bigman number is the ability of a structure to move a viscous liquid. The next one, please. This is very interesting. This is the characteristic of the foam with the VARIXIO, with the Varitena. You know that Varitena is the foam used in the United States with the Cervi, and you can see that for the VARIXIO, when you use VARIXIO, the Bigman effect is very important. Bigman effect is to move, to displace the blood. And this is very important for the hemorrhoids, because if the blood remain in the hemorrhoids, you can have pain, you can have problem for the patient, problem the patient call you, or I have pain, this is not a correct procedure. With the VARIXIO, all the blood displays and remain all the foam inside the varicose vein, also the hemorrhoid. The next one.
Però non li prende, non c'è l'anguilla buona, questa non l'ho preso. Io ti consiglio, io per rossa sto col gambero dentro,
The injection.
la tarta di ambrofobo.
The injection
Edoardo,
is
Edoardo, scusa Edoardo, perché per una questione, because we don't have enough time.
Question of time.
Yes, can you go to your main messages? Maybe you can have a summary of your technique and go to the main messages.
Yeah.
Because we saw
we have 1 hour. We have 1 hour.
Yeah, but okay.
The next one.
Okay.
Okay, I understand. Yes, yeah. Let's go, please. Let's go. Okay, let's go. I think that it's very important for me, 2 ml of foam injected slowly. Slowly is very important for the vein and for the hemorrhoids. Attention, Gaetano spoke about this at 11 o'clock position, because we have the prostata. The only problem for this technique is 11 o'clock for the prostatitis. Okay, this is very, very important. And very slowly the injection. I inject only 2 ml for every hemorrhoid. Let's go. My treatment, three times every 30 days. Okay, 3 sessions, 1 every 30 days. Let's go. Tip and tricks: don't inject the foam then 5-6 minutes to avoid touching the rectal muscle tissue. Don't inject more 2 frees per single hemorrhoid. Don't inject then 8-10 cc per session. Perform at the least 3 sessions, 1 every month. No bowel preparation is necessary. Let's go. The only problem, prostatitis. But if you inject only 2 millimeters at 11 o'clock, you don't have this problem. Let's go. Let's go. Okay. I perform also with endoscopic technique. For the vascular, for the general surgeon, this technique is possible also in endoscopic with a retroversion retoscopy. Let's go. I perform this technique when you have 3 degree, and I prefer, let's go, to treat with endoscopy in the 3rd degree. Let's go. The next one. Okay, it's sure that you have, this is the endoscopic technique, and let's go, please. This is very important. Anoscopic technique, one operator, lower cost without sedation. Okay, disadvantage, minor visualization. For the endoscopic technique, you have better visualization, of sure, but higher cost, almost do operation, and sometimes with sedation. Okay, let's the next one. Oh, let's the next one, please, because we have no time. Benefit, more cost-effective treatment, particularly suitable for the first, second degree hemorrhoidal disease, is combined with other technique. The best choice is with bleeding, when you have bleeding of the hemorrhoid. The next one, repeatable, complication rate is lower, several side effects, hemorrhoidal tissue is preserved and remain intact. Patient took it, anticoagulant can be treated. Let's go. Effective, safe treatment option, least invasive treatment possible, can be performed in patient, does not require anesthesia. This is the same thing that Gaetano spoke. Okay, let's go. Okay, it's finished. Thank you so much.
Thank you, Edoardo. Thank you very much, Edoardo.
I think we have just 3 more questions and that's it.
Okay, let's go. Dalina.
Did you have any local infection after hemorrhoid sclerotherapy?
No, no.
Gaetano.
Never.
Yeah, I tried to answer to Repli already. So no infection at all, no necrosis, no any other problem, no other sepsis. No, never.
And
Never.
can I add, do you apply any antiseptic or any kind of topic? Nothing. Just
Topic,
okay.
well, topic, yes, in the post-operative period. So cream, like for example, like I said, 3% sacral fat-based rectal ointment, or any other similar cream with flavonoids, or lidocaine gel, maybe for patient with a bit of higher resting anal pressure, but usually no. I used to do that in anal fistula after surgery, but not in those type of patients, never.
Okay. Second question, Dalina.
I think that Dr. Gallo already answered. When do you use rubber band ligation and when sclerotherapy? How do you decide?
Well, I try to summarize everything concerning that sclerotherapy is better in bleeding patients, because in those patients, rubber band ligation is contraindicated because the risk of bleeding is exactly based on the pathophysiology, on the rationale of the action of rubber band ligation. So you will lose the band after 3-4 days. So it's exactly this is exactly the problem. As I said, rubber band ligation can be more useful maybe for the prolapse in normal type patients. So I mean, just second, third degree, if you really believe in the Golic reclassification, because otherwise we can say that regardless of the degree, sclerotherapy is better for the bleeding control and also a bit for the prolapse, and rubber band ligation maybe a second procedure or combined if someone else can do that, for combined in patient with prolapse that can be second or third degree hemorrhoidal disease.
Okay. Edoardo, do you want to add some comments?
I have a question for Gaetano. Gaetano, in another country, I know that you go to China, in another country, all around the world, which percentage of polidocanol is like in Italy 3%, or in another country you can use another percentage, 1, 2 of polidocanol?
Dr. Gallo, you're mute.
Gaetano.
Thank you. As I said,
for example, in China, I know
Yeah,
that
here
you.
in Italy is allowed this only the 3% for hemorrhoids. We know
Yeah.
that we cannot use for medical from the medical legal point of view, we cannot use the other percentage. In China, also in Portugal, I think they use as well the 1%. Just to add something, the 3% is more expensive than the 1%, and so they try to do that. At least this is in China, so this is different. Well, it's really more expensive than the 3%, and so that's why in the past they used to perform sclerotherapy with 1%. Well, but now everything is changed in the last 5 years at least, and also in Portugal, in Jordan, in all the places I've been, they use the 3% with a small percentage of colorectal surgeon or vascular surgeon or proctologist using the 1-2%. But a good question, Edoardo.
I
Thank
would
you,
like to.
Gaetano.
I would like to
Thank you
say
for
that.
your experience and for your publication.
Yeah, I would like to ask, just to point out that there is a problem of authorization of different concentrations depending on the countries. What I would like to say is, it is not exactly illegal, but is an off-label use. So because it's different. I would say that if you want to use 2% or 1%, of course, the reaction or the inflammatory reaction could be less than the 3%.
Yeah.
Maybe it's a balance. There is a balance between the effectiveness and the reaction. But as you mentioned, Gaetano, if your experience using the 3% is enough good, I would say, okay, is the maximum concentration. Maybe the lesion of the endothelium would be better than if you are using the 1%. So then, if it works, I think it's okay. The 3%.
Yeah, no, it's well, Eric, this is reasonable. It is reasonable. I'm not saying that it's illegal. I'm saying that if in Italy, because in Italy we need to pay attention to all of this, I think also Spain and all the other countries, but every one of us try to spread out our experience in their country. And I think that in Italy, if you perform sclerotherapy with 1% and you will experience some problem, you will get in trouble for sure.
Yeah. Okay.
Not because it's illegal, but because it's not fully declared the use.
Yeah. Understand. Dalina, is there any other?
No, we don't have any other questions. So thank you all very much for joining us today. Thank you, Dr. Gallo and Dr. Cervi, for being here with us. If you have any further questions regarding this section, don't hesitate to reach out to hello@varixio.com. And thank you again for being with us today, and have a wonderful evening.
And remind that it will be recorded.
Yes.
And then all the speakers and all the attendees, they can have a link to download the presentation and to, of course, to keep on talking about these interesting topics. Thank you very much, everyone. Thank you very much.
Thanks for inviting me, to all the team. Very pleased to do that.
Okay,
ciao.
Thank you.
Thank you. Ciao, ciao.
Bye.
Bye.
Bye. Bye.